Hello, everyone. I hope all is well. My name is Shania, and I will be providing some education on the importance of completing a full head to toe assessment, hospital edition. All right, so first things first, objectives. When you think about objectives, just think of an aim or an end of course action which is to be reached over an amount of time. In this case, by the end of this presentation. There are four objectives that each one of you should feel comfortable with by the end of this presentation, which are: one, the nurse should be able to verbalize at least one possible abnormality associated with each body system. Two, the nurse should be able to properly demonstrate a complete head to toe assessment. Three, the nurse should be able to verbalize the times in which a complete head to toe assessment is necessary for a patient. And four, the nurse should be able to verbalize why accurately completing and documenting a complete head to toe assessment is vital in the hospital setting. All right, so next up are our goals. The goals that I have set are long term and are followed up by the understanding of the objectives tied in with an implementation of actions, which will be covered in this presentation. We have three goals. Goal number one is after the completion of this presentation and implementation of proper assessments through accuracy and time, there will be a 25% decrease in HAPIs over the next quarter. Goal number two, after the completion of this presentation and demonstration of a complete head to toe on an assigned patient, new abnormalities found regarding the patient are addressed within 24 hours of admission or transfer to the unit by the patient's healthcare team. And three, after the completion of this presentation and enforcement of required assessment charting, the nurse will be able to effectively identify risks that may cause new abnormalities and set up safety measures to decrease these risks. All right, so remember in school when we had to know the 5 W's: who, what, when, where, and why? We're going to answer these, but from a nurse perspective, as it correlates with the comprehensive assessment. Who does it? The registered nurse that's assigned to the patient for that shift. What is it? It's a head-to-toe comprehensive exam of the patient's full body that includes all systems, assessing for proper functioning. When is it done? At the start of the shift, admission, transfer, when a patient returns from surgery, any change in condition, and at discharge. Where is it done? In the patient's room. Being sure to introduce yourself, what you're doing, providing privacy, especially since the patients are 2 to 4 in this hospital setting per room. You want to make sure that they have the curtains closed. If you need to ask anybody to step outside of the room, just want to make sure that the patient feel comfortable. And why are we doing it? We're retrieving a baseline of the patient, including his or her clinical status and behaviors. It is important as the nurse to be able to be aware of any changes that may occur in the patient's condition. Also, eliminating and decreasing risk for illness and infection for the patient or the patients. For example, if a patient is not eating, poor appetite, what does that put them at risk for? Skin breakdown. So just kind of making sure you know what's going on there. Right. So I am sure that you all are competent in how to complete a head to toe assessment, but I did want to do a brief overview of the systems that should be assessed and what should be assessed in those systems. I recommend printing out a blank assessment sheet for each patient, maybe even one with an outline of the patient's body that you can just have when you're doing your assessments in the morning, just to make sure you don't forget any body systems. We have neuromuscular, neurological. This is the patient's orientation status. Are they confused? Short-term, long-term memory. We're looking at headaches, dizziness, their swallowing abilities. You do a lot of charting in this portion for your stroke patients as well. So that's something to keep in mind. Be into head, ears, eyes, nose, and throat. We're looking at visual changes. Are they legally blind? Are they deaf? Do they have oral thrush? Just doing assessments there. Respiratory, we're looking at breathing patterns. We're looking at do they have a trach? Do they have oxygen needs, BiPAP, CPAP, how they're breathing. Going down to cardiac, are they on tele? Do they have a pacemaker? Any edema? We want to make sure that we know all of this. Again, just kind of making sure we have that baseline. Gastro, genital urinary, do they have any devices? Are they continent, incontinent, things of that sort? Musculoskeletal, their strength. Are they bed bound? Times 1 assist, time 2 contact independent. And then skin assessments. Do they have a wound vac, hematoma, any devices? So just kind of looking at this outline, kind of just making sure you know what abnormalities to look for in your patients and that you are assessing and documenting as you should. Question of the day: how did I miss it? The reason I'm stressing the importance of these assessments is because this service that we are doing to our patient when they're not done. So let's think about the patient that comes in and from admission they have loose stools. It has not been documented. The nurses haven't taken the time out to assess the stool, question the patient about how often or how long it's been going on. And 3 weeks later, a nurse finally decides to, and the patient tests positive for C. diff. The patient, other patients, family members, and healthcare staff are all now at risk. And now let's get into the two pictures that I have at the bottom here. We have our young gentleman here with the facial droop. Let's imagine this patient was in bed sleep and the nurse decides not to assess him, but instead copy what the nurse put prior. And this is a new change. Was a workup done for a stroke? Was a swallow valve done before the patient attempts to eat and aspirates? Or maybe even the patient with the wound here. Was it tended to? Has a walk console been placed? Is it being cleansed and changed appropriately? And if not, the patient is at risk for complications, even as bad as sepsis. So skipping an assessment is so much bigger than what one may think. Now, there has been an ongoing issue with proper assessments being completed. And when issues are brought to the light, I believe a solution should be as well, which is why I have come up with some implementations that can be put into the unit to basically help with getting these assessments done, following up with them, and things of that sort. So I have 8 of them. 1, it takes 2 skin assessment. When a patient is admitted, grab another nurse. You both assess together. You both document your names. Accountability. Wound pictures, done every Wednesday. Hourly intentional rounds. That's between the nurse and that's the aide, anyone else in the healthcare team, going in, assessing the patients, checking their needs, checking their body. Are they wet? Are they soiled? Lines devices being checked every Sunday. Are they dated? Are they being changed how they should be? Is the tubing correct? Just making sure that everything is done there. Another decrease of risk. Complete assessments once per shift. Audits being performed. Completing head-to-toe checkoffs for new grads, charge nurses, instructors, educators, travelers. 7A to 7P huddles daily and rounds with care team, whether that's the MD, nurse, social worker, all being together discussing the patient and what's next for the patient. So, quiz time. Can an LPN complete an initial assessment of a patient? No. You're running behind on your medication pass. Can you copy and paste the head to toe from the previous shift? No. You received a transfer from the ICU to MedSurg. The nurse that gave you your report states that she already completed the head to toe for today. Do you still have to complete one? Yes. How many people are needed for the skin assessment that must be completed once the patient arrives to the unit? 2. You have a 30-year-old walkie-talkie patient who is alert and oriented. It is time for his head-to-toe assessment, but the patient is refusing, stating that he has no abnormalities and everything is normal. How would you handle or document this? There's a couple things we got to do here. 1, stress the importance of head-to-toe to the patient. 2, of course, the patient has the right to refuse. You want to make sure that this is documented. So you're not going to put within normal limits if you have not seen it, if you have not assessed it. You're also going to let the provider know that the patient is refusing this assessment so that you're not able to gather the baseline that you need for this patient. You cannot put within normal limits just based off of the patient saying it. This is something that you have to assess and document for yourself. All right, here we have some references just in case you want to look deeper into the information that was provided. And that is the end. Thank you so much for watching. This is the end of the portion of education. Please review and comment if you have any questions that you may have. Thank you so much for your time, and I'm excited to see what happens next.